All right. So thank you both. With that, I'll go ahead and introduce our panel. So first we have Dr. Kathleen Bechtold, who is Associate Professor of Physical Medicine and Rehabilitation, as well as the Director of Psychology Training at the Johns Hopkins University School of Medicine. She also serves as the president of the American Board of Rehabilitation Psychology and is both board certified in clinical neuropsychology as well as rehabilitation psychology. We also have Dr. Kirk Stucky, who is the director of the Advanced Neuropsychology and Pediatric Psychology Services at Hurley Medical Center, and is also the program director for the Postdoctoral Training Program in medical psychology with specific areas of emphasis in both rehabilitation psychology as well as clinical neuropsychology. Dr. Stucky is also board certified in both clinical neuropsychology as well as rehabilitation psychology. So thank you both for being here. Very excited to have your insights and just really appreciate you guys taking the time, especially on a Friday afternoon. So thank you. But with that, I guess we can go ahead and get started. So I guess generally we were hoping to start out maybe with a question for both of you, and then maybe as things come up or others have other questions, feel free to just answer them or message either Coley or myself or Kristen. But with that, I will pose the first question, which is, how do you identify as a provider on the spectrum of rehab versus neuro, and how did you become interested in this general area?
Yeah, that's a wow, and I saw the questions ahead of time. It's just that's such a big question. So how do I identify? So at this juncture in my career, which I've been at this quite a hot minute, I would say that most often when I introduce myself, I say I'm a clinical psychologist who specializes in clinical neuropsychology and rehabilitation psychology. And it's more honoring both my specialty areas of practice and knowing that they both are beloved. So I would say I'm right smack in the middle with them, and adore them both, and couldn't do the job I do without both of those specialty areas. And they play a role every single day of the work I do, whether I'm wearing my training director hat, whether it's clinically working, my research or developing some of the programs that I'm currently developing, clinical programs. So it's just right smack in the middle. How did I get there? Oh boy. Well, back in 1492, there were no postdoctoral fellowships in rehabilitation psychology. Actually, nobody knew what the heck that was. Not totally true, but I was so enamored with the brain. I was enamored with the brain as an undergraduate. And so I was a TA as an undergraduate in brain behavior, which we all took, right? We all took that class if you love the brain. So I actually TA'd that course and then started taking grad courses as an undergraduate to learn more about the brain. And so my love for the brain and knowing that I was going to go into neuropsychology started when I was, just a wee one. And so from there, it really was just continuing to develop that. However, in grad school, I happened to have the incredible experience of being in the city where the first post-acute resident neurorehabilitation program was developed in the country, which is sweet old Carbondale, Illinois. And so had the opportunity to be on the ground with a rehab team right in my training, which was an incredible experience. And so understood, got to understanding the power of being able to do intervention. So I would say that it was a love at first sight of saying, here's what I gleaned from neuropsychological evaluation and understanding the brain and brain behavior relationships. and rehabilitation allows me to do, and so what are you going to do about it? And I'll just sort of end with that comment.
Sure. So I guess I'm on deck. So I started a little bit differently. My internship out of my doctoral program was actually called medical psychology, and so was my fellowship. But similar to Kate, there really wasn't any sort of neurorehabilitation merger. But in Michigan, I had the benefit of Mitch Rosenthal and Scott Millis, who were down in Detroit, and they were essentially your early, I think, folks that were doing both neuropsychology and rehabilitation. So they were early role models for me. They never trained me officially, but Scott and I had a long-term relationship. And he actually, the hospital paid for some extra supervision for him while I was in fellowship in medical psychology, because my program director was a health psychologist. And so even after like 6 months into my first year as a fellow, he'd said, gosh, there's some things that you're wanting to learn that just I don't have the skill set for. And Hurley was in the process of developing their inpatient brain injury rehab unit, and I was kind of front and center on that. So I had the really good fortune of having some early role models and mentorship that I think we're living in both those worlds, clinical neuropsychology and rehabilitation. In terms of day-to-day, most people refer to me in the hospital as a neuropsychologist, and I think that's mostly because rehabilitation psychologist is too long. And so I've never really established rehabilitation psychology or announcing myself that way regularly, although it's on everything that I do. So like my title is neuropsychologist and rehabilitation psychologist. I haven't adopted the term that's been floated out there of neurorehabilitation psychologist. And that's mainly because it's just not recognized yet by any of the professional organizations as a, I guess, a vetted title, if you will. But as some of you know, we've kind of endorsed possibly that way of kind of describing oneself. And I know a number of programs do. But if you're just asking me personally, a lot of times people refer to me as a neuropsychologist, but I use the term rehabilitation psychologist in introducing myself all the time. Hopefully that answered the question fairly well.
Yes, it did. Thank you.
Oh, absolutely. I think we all really appreciate hearing both of your perspectives. Also, just thinking about how this area has evolved over time and recognition for neuropsychologists in different spaces, the blend of rehab and neuropsychological practice. I think Kristen said in the chat that transition from neuropsych knowledge to rehab action, and I definitely agree. There's a question in the chat from Jenna. So that internship, fellowship, and professional experience has been strictly rehab psychology up until this point. Do you have advice about how to pivot into getting into neuropsychology experience and specialty without any previous training? Or maybe just how to carve out those experiences?
Yeah. Is that person, I'm sorry, is that person still in fellowship or are they done with fellowship?
I am done with fellowship and I'm currently academic faculty at a medical center.
Okay. Yeah. You know, of course, there's a lot of neuropsychology resources that are out there in terms of neuropsychology, navigating neuropsychology and things like that. But I would say there's no really replacing, you know, having somebody who's really skilled at it, providing some supervision. So if there is any way to develop a mentoring-like relationship with a neuropsychologist, obviously preferably somebody board certified, that'd be one avenue I would consider. You might find some folks that are a little bit reluctant. People are really busy, but I know that some people have kind of followed that avenue. It's pretty rare, I think, for folks to go back and do another fellowship. You know, and I know, Kate, I think there's 23 of us double boarded folks nationally, but I don't think there's one of us that did 2 fellowships. So it's kind of one of those odd things versus like saying like medicine, It doesn't work that way, but in psychology, you can essentially kind of develop other competencies. But if you were looking at eventually getting board certified, it might be kind of challenging if you don't have a prior history of supervision from a board certified neuropsychologist. I don't know what Kate has to say about that.
Yeah, happy to put my ABAP hat on for a second here. It is challenging. I would say that there is encouragement to have folks get board certified in areas that they practice in. And so if a person had an interest in expanding their practice areas, their specialty areas of knowledge, and that's applying those skills, which is what competency is defined as, then you would want to go out and expose yourself to that specialty knowledge. And so to Kirk's point, to go and find experiences that allow you to develop those skills. And there's ways to do it. And it doesn't matter if we're talking to go about going from rehabilitation psychology as your specialty area that you've really been steeped in, and now you want to add on our clinical neuro, or the other way around, either one. I would, there are opportunities. Is it a lot? It's extra work and extra time and a lot of commitment. And it is with partnerships with individuals that are board certified in those specialty areas that would need to supervise so that they could endorse that you've been exposed to that specialty knowledge. So with that said, I would say that there's more and more openness from the board's perspective to looking at a person and a psychologist and saying, oh, you say you've been exposed to this specialty knowledge, and looking at the variety of exposures and being a little more open to that it wasn't the traditional route, that you know, did these graduate classes and did this internship and then did this postdoctoral fellowship, that there are other pathways to accomplishing that. It's possible. It would be a dedicated effort that would take some a large amount of time, and there's people pursuing it right now.
I would add to that, I sit right now on the ABCN credentialing committee. And when we're looking at that, now these are folks that are applying to become board certified. So this is the credentialing process to determine, do they have the background? And we're looking at, one, did they have a 2-year fellowship? 2, does it meet the Houston Conference guidelines? 3, do they have endorsements from supervisors who can attest to them completing the program successfully and obtaining the necessary competencies? We do have those folks that come through non-traditional tracks, though, that are able to demonstrate that, but it's pretty detailed. They will provide very detailed lists of courses that they've taken, supervisors that they've had, the patients that they've seen, and then also have the endorsement usually of, you know, board certified neuropsychologists attesting to, even though it was, say, a non-traditional or a non-APPCN program, that it met those criteria. And those folks have been able to get through. But for folks that had, say, less than a 2-year fellowship, or have really no formal training exposure to neuropsychology, it's pretty hard to get past the credentialing requirement.
Yeah, to add on, it would just, you would need to pursue that coursework. You would need to pursue that supervised training. And notwithstanding, you would have to complete what would be akin to a second postdoc, maybe not in the traditional sense, but you would have to pursue that. So just as an example, the military has a program for psychologists to complete a postdoctoral fellowship. And this is for individuals who are out practicing in the military. They're licensed, they've been providing services as a psychologist, and now they want to complete a postdoctoral fellowship in neuropsychology. So those folks literally come out of working and take and are given the time, and like frankly, they are actually paid to do this, but then complete that additional postdoctoral fellowship so that they can add that specialization of clinical neuropsychology on. So there are opportunities to do that. There are pathways to do that. It is extra and dedicated.
I'll also say that for years, my program was not an APPCN member. There's reasons for that I won't get into, but I've been doing the neuropsychology training for well over 25 years. And so for a while, those folks that were kind of, I'd say, what I'd call a neuro rehabilitation training program that were getting both rehab psychology and neuropsychology. I, as the training director, even though it was an APPCN, could essentially attest to that and write a letter that usually the board recognized. So I really do, having been on the board and being board certified, I really do think there's a desire for folks to become board certified to recognize folks that have specialty level expertise. So just because you haven't been in an APPCN program doesn't mean you can't become board certified. But there's just specific steps you want to make sure you take if that's your goal eventually.
We actually do have a kind of related question on, I will pause on that actually, because we just got a question in the chat that I will read first. But for those considering double boarding in both rehabilitation psychology and clinical neuropsychology, is there an advantage of doing one before the other and or doing both simultaneously?
Ooh. I don't know the answer to that. I think it probably depends on the individual. I'll just say that I did rehab psychology the first year, and then I did neuropsychology the next year. That was mainly just because the workload to do both at the same time would have been a little bit daunting with a full-time job and other things, but that's how I did it. And in some ways I did it that way because Scott Millis, who was my mentor, suggested that be, the smartest route to go. And rehab has really always been my primary home. That's where I really cut my teeth early on. So I've always kind of identified with the rehab, I guess the neuro-rehabilitative setting. That's where I've spent pretty much my whole career, in addition to critical care and ICU settings. That's been my home for 30 years.
So I too, just my experience, I did rehab psych first, and then I did clinical neuro, mostly probably because at Hopkins in the Department of Physical Medicine and Rehabilitation, it's one of the main seats of rehabilitation psychology. I mean, that's where Steve Wegener is there and has been there. He's the one that developed the division. And so, there's movement, encouragement. So to add on to that and to actually echo what Kirk said, I would not encourage people to do them at the same time. They have different, slightly different requirements or processes, and you wanna be able to focus. You're talking about you're taking the knowledge you have in your head and displaying it. The board is examining all that knowledge is in your head. So I would encourage folks to focus on one knowledge set, one specialty area of practice, and then go to another. Just because it's a lot to data dump all of that in the various ways that you're asked to do it, depending on whether you're talking about RP or CN. And order-wise, I mean, there is something to having one under your belt to go, oh, I can do this. It also defrays some of that mystique of going, it's intimidating and stressful and overwhelming, and you go, okay, they're actually lovely people, and they just want you to be successful. They want you to feel comfortable to show all that specialty knowledge you've gained. And so I would say maybe the advice I would give is choose the one where you go, I feel like that's maybe my home or my main, I lean more towards clinical neuropsych, then maybe, start there, because that's your bread and butter, right? And then add on rehab psych, which is really about understanding disability and how disability is created and how do we work with individuals that have disabilities to help them engage in life in meaningful ways.
Thank you both for that. Looks like we have another question in the chat. So how does the everyday work of a rehab neuropsychologist differ from a neuropsychologist working with neurological or medical populations? What drew you to rehab over other specialties?
Hey, do you want to take that first? I think I spoke first last time.
Yeah.
Not to put you on the spot, sorry.
No worries, no worries. So, yeah, so rehabilitation neuropsychology is what I said a little while ago. You take all this wonderful knowledge about how this lovely gob of goo works and how that affects how we're able to behave and guide our behavior and interact in lovely ways, and then applying that to what does that mean for this person's life. And so I would say that as a rehabilitation neuropsychologist, my day-to-day work life is one of that, taking that and applying it with human beings to help them move forward, engage, reduce disability. And whereas if I only was wearing my clinical neuropsychology hat, I would be understanding all of this and providing very helpful information about how this is operating, maybe where some hitches in the giddy up are and what to do about it, but I'm not applying that with those individuals. So it's providing the guidance and weaving together what would be helpful. But where the rubber hits the road, in my mind, rehabilitation psychology helps me to apply all of that and how that individual can adapt, adjust, so that they can engage fully. And so it really is more those two pieces together than allows me to do the full picture.
Yeah, I'd agree with that. I just add this. I had a physician mentor. He was actually an orthopedic surgeon. He said in hospitals, there's two types of doctors. There's thinkers and there's doers. And you got to figure out which one you want to be and which one you are. So thinkers are like internal medicine and radiologists. I would also put your traditional neuropsychologists in the thinker category. Pathologists would be thinkers too. Doers are surgeons, right? Doers are people that are actually doing interventions. And so I think a neurorehabilitation psychologist is both a thinker and a doer. They're doing both. But when I talk to colleagues that are what I would consider traditional neuropsychologists, they're kind of test and release kind of folks. They'll test the patient. They do a great job. They give helpful information, but they're not necessarily getting their hands dirty with the treatment. They're not going to be doing psychotherapy. They're not going to be doing family interventions. They're not going to be doing team interventions. They're not going to necessarily, they're going to be maybe acting as consultants. Now, I would argue that there are some neuropsychologists that call themselves neuropsychologists that are out there actually doing neuropsychology and interventions. They are doing that. They may not call themselves neurorehabilitation specialists, but they are. Because if they really do have an understanding of disability rights, for example, and rehabilitation-oriented competencies, and they're applying those, guess what? They are doing both. They're not just doing neuropsychology anymore. Even though they might kind of identify just as being a neuropsychologist, I would argue that they're branching out. They're doing more than that. So I guess, if the question is kind of like what your life looks like and what it feels like, if you really like getting your hands dirty and really getting down into the nitty gritty with families and like dealing with crisis and being on the ICU and dealing with depression and anxiety, dealing with behavioral issues and trying to figure out how to get this person to maximize their rehab program, neuro rehab might be the very thing for you. On the other hand, if you would rather test folks, think about the brain, really spend a lot of time thinking about it, write a really good report with recommendations, and then be done, then maybe traditional neuropsychology is a better fit.
We also have another question in the chat, which says, as a fellow in a rehab postdoc with training in neuro, I am now seeking employment, and it seems everyone defines the terms rehabilitation or neuropsychology differently. Do you have any suggestions as to how I ask each employer what their definition is?
Well, I think you're spot on. I think there is a lot of variability in things. And I look at ads and there's a lot of variability in just like postdoc ads and job ads. And part of that is on us as a profession. We haven't really, I think, evolved to where we probably need to get to with this area of overlap, which quite frankly has been there a long time. And we don't have time to get into the minutia probably about organizationally why it hasn't evolved more, but what I would basically ask is the person who's recruiting you and hiring you and the people that work there, actually ask them the same questions you guys have been asking us. How do you define yourself? What's your workday look like? What are the job responsibilities and why is that? Kind of what's your philosophy of care? And that should give you a pretty good idea of kind of which angle they're coming from. And some groups might be a little bit more neuropsychology heavy, others might be a little bit more rehab psychology heavy. And then you have to determine, is that a good fit for you or not? I think it can be done in a lot of different ways, but I think various programs across the country, kind of have their own unique slant to it.
Yeah, absolutely. And some other ways to maybe query this is to really ask them to define what the role of the psychologist will be. And so, some terms like, well, you'll be a consultant on the rehab floor or in the hospital versus you will be a team member. And so how they conceptualize your role can help you to glean whether they're conceptualizing you in that model, which really is part and parcel of rehabilitation psychology, is that you are a member of the team because you're integral to what happens with that process. The other piece to remember is that rehabilitation psychology is a misnomer. At least that's how I think of it. It would tell you that I've said over and over again, because it really is disability psychology. It's really understanding how disability is created. So there's many people that could work on a rehabilitation unit or work with a rehabilitation hospital system and not be practicing rehabilitation psychology. And so to query what are they hoping that you as a psychologist would do with the patients? What roles do you think that that I can serve? What does the team want from a psychologist? What do you want from me to be able to do for patients and for the team? Can also help to glean where they say, we want you to evaluate whether they can engage in, the rehab process, or versus we want you to be intervening and helping that person to be part of their recovery process, provide education, and sort of more of the elements of what would be a more of a team member that is helping along with that recovery.
I love that. And thinking about what are the specific opportunities, questions, environment, and asking questions tailored to those to get an idea of what will your role be. I think a follow-up question is just how that can be applied, and how you can ask those kind of questions maybe earlier in training stages, either for applying for postdoc fellowships or even when you're on postdoc, like how to talk with your supervisors about carving out those specific experiences. And before answering that question, I just saw that we are very fortunate to have our third panelist join us, Dr. Carey Pawlowski. She is a board certified rehabilitation psychologist at the VA Palo Alto healthcare system, working at the polytrauma rehab transitional program or transitional rehab program. She is I'm so happy that she's here and can help add another perspective.
Thank you, Dr. Evangelista, and my sincere apologies for my tardiness to this presentation. I appreciate everybody's patience with me.
Welcome to the party.
Thanks, Dr. Stucky.
And just to repeat the question, just in case you were able to catch it, Dr. Pawlowski, just thinking about how can people who are earlier in their training stages, maybe not yet applying for jobs, but applying for postdoc or on postdoc, think about questions they can ask to make sure they're going to be in a program and find a good fit for themselves that support opportunities for success as a rehab neuropsychologist in the future, balancing requirements for board certification, and make sure they're able to build those competencies.
So you're saying, so people who are not quite ready to apply for postdoc, who are like earlier in the stages, is that what you're saying?
That are not quite ready to apply for jobs. So more
for jobs, sorry,
like applying for postdoc at the postdoc level.
Got it. Okay, yeah. Have the other panelists already addressed that issue?
Not yet. The question was
Okay.
just asked.
I'll go ahead and have Dr. Stucky or Dr. Bechtold, if that's okay. I'm still catching up from being here, so.
You want me to take it first?
Yeah.
So I'll take it from the perspective of that we have had for quite a while a postdoctoral fellowship in clinical neuropsychology, where we say the type of applicants we want are folks that want to intervene. They want to learn so what do I do now to help this person? And so asking those questions of what do the type of clinical training experiences look like? How much time is spent more on the assessment part versus learning intervention skills? What are the types of intervention skills? And what can help with this is going and looking at the competencies that define clinical neuropsychology and define rehabilitation psychology, and then it arms you a little bit of going, well, what are the elements for understanding, some of the brain behavior relationships, or understanding, neuroanatomical underpinnings of this disease process, versus, hey, does your postdoctoral training have the opportunity to look at how pain interacts with the experience for somebody that's had a traumatic brain injury, or learning about sexual functioning and how that's impacted by a brain or spinal cord injury, or by multiple sclerosis. So it can help you to look at the what knowledge underpins those specialty areas of practice, and then you can ask and look at the parameters of those training opportunities and say, do they hit that? Do they offer those opportunities?
Yeah, that makes sense. I agree with that. And if I could jump in too, and actually want to give a shout out to somebody who's on here, Dr. Molly Keith, who reminded me of a conversation she and I had years ago at a Division 22 Rehab Psych conference about identity. And so here, Dr. Stucky and Dr. Bechtold are dual boarded in neuro and rehab, and I'm boarded in rehab. And I back on internship, actually, I was a neuropsychology intern, and then progressed to my current role in terms of rehab psychology. It really is my focus and my passion. But the conversation that Dr. Keith and I had years ago was about identity, and we talked about big N or big R, so N for neuropsychology, R for rehab psychology, and sometimes kind of thinking about our experience that we've had on internship or postdoc or jobs in early career stages, and sometimes it's an evolution of our values, our passions, and sometimes it's an evolution of what the actual opportunities are on in the job, and sometimes it's a kind of evolving. So like sometimes, maybe back 20 years ago is a big N, and then sort of an emerging R on internship, when my training director helped me realize that actually is something that I had a passion for. Now I'm a big R and a little tiny N. So where are you, just kind of thinking about all the people who are here, attending this presentation, like where are you in the process of that big N or big R, medium N, medium R, and kind of evolving? It can certainly evolve over your career too.
Yeah, I like that. I would add too, you know, like when I go into a patient's room or a meeting with other physicians, I don't think to myself, okay, I'm going to be a neuropsychologist now, or oh, I'm going to be a rehab psychologist. I'm just who I am and have this unique skill sets. And all of you have very unique skill sets. And so I would say, especially in medical centers, don't let people define who you are. I mean, obviously, you're not going to go start saying, okay, I can do surgery or things like that. There's scope of practice issues, but at the same time, there are so many areas I think that somebody with a neuro rehabilitation skill set can apply those skills successfully. So, you know, for example, neurorehabilitation could easily be applied to, say, post-cancer care. Or I've written quite a bit with some folks about folks that are critical illness survivors who oftentimes don't get the level of rehabilitation care that folks with stroke or brain injury traditionally do. And that some of that is because of just the way the pathways are set up in medicine, that sometimes it's just not thought of, that these folks on the ICU or survivors of critical illness need those kind of services. So, you know, you can develop those skills and you can develop those niches, and some of that's dependent on what opportunities are available in your organization and what inroads you have. But, you know, build alliances and kind of, you know, look towards people that are doing those things, and then ask lots of questions and pursue it. Because I really feel my personal bias is that psychologists aren't involved nearly in as much as they could be. And there's reasons for that that aren't just, say, you know, not enough training programs. Some of it has to do with just there hasn't been a tradition of that at that particular institution. And so there needs to be basically a trailblazer that comes in and says, hey, by the way, did you know that psychologists can also do this? And oftentimes the answer is the physicians and the administrators and the folks, they don't know because they've never met a psychologist that does X, Y, or Z.
Yeah, that's a great point, Dr. Stucky. Actually, in terms of like not letting others define you, like you're defining yourself. It reminds me of, I don't know, probably 3 decades ago, I was at NAN, in National Academy of Neuropsychology conference in San Francisco, ironically. And I come to my PhD is in counseling psychology. And so I had done a lot of practicums at rehab hospitals and so on. And so I, you know, was drawn to the neuropsychology profession. But I will never forget, I was in the elevator with some other person at the conference. And, you know, I think they saw my name tag, like where my program was. Anyway, they said, oh, counseling psychologists can do neuropsychology? I'm like, oh boy, okay. So some of it's, you know, like, right, like we all take the same exam, you know, so really it's identifying it for yourself first, and then also being able to, if you don't have the traditional pathways for neuropsych or rehab psych, and actually I didn't, not a lot of people in my program had actually done a lot of practicums at rehab hospitals, but I created those pathways. And then certainly, like Dr. Stucky was saying, subsequently, it's being able to then forge those collaborations with, you know, maybe it's other people in the profession, maybe it's other disciplines. That's a huge piece, certainly, that's helped me in my career, is like the mentorship and the collaboration with other psychologists and other disciplines, for sure.
As a follow-up question, because I think we've talked a lot about, you know, that there's non-traditional paths. You want to maybe be a trailblazer and you know, forge these collaborations and help people understand and increase understanding of what our role could be in different spaces. I'm wondering if you have any specific guidance or advice for folks who may not have access to mentorship or readily available or opportunities for folks to be able to forge those collaborations, or maybe how you see bridging the rehab and neuro worlds in the future so that these opportunities become more accessible for trainees.
Sure.
That's
Would
a
you like me
big
to start
ask.
first? Oh, go ahead.
No, that's a really big ask. Boy, how do you address that? I think that the way I think about the professions, clinical neuropsychology and rehab psychology, clinical neuropsychology is a bit ahead in terms of its development, but I would still say it's a young adult. Rehab psychology, even though it's been around for a while, is still adolescent. And there's certain things that are developing and those things are moving forward. I've been involved in the organizations, they're great. But if you compare those to, say, the level of sophistication that some of the physician boards have and the way in which things are done, it's different. Not to say it's better, but it's different. And at an organizational level, there's certain things that they have that we just don't yet. I hope that before the end of my time on this earth or this reality, whatever, that will evolve, but I really don't know. I'll just say, personal experience, I think we've got tremendous talented people and a lot of people that want to make this happen, but there are certain things you got to kind of convince folks to kind of move that way. So just an example, maybe a shameless act of self-promotion, but like the article that I recently authored with 6 others on neurorehabilitation, we had actually pushed that initially as, let's make this a joint venture between Division 22 and Division 40, and let's make it maybe a best practices paper or a position type paper. And I'll just say that those 2 divisions were not ready for it. They just weren't. And we don't need to get into why. But that article is now published. It's published in PM&R. And the reason that it's there instead of a psychology journal is because the other journals didn't want to touch it. It's kind of a hot potato topic still. I think a lot of people get worried about scope of practice issues and people kind of, being very protective of the specialty. And I get that. But I think this is an area we really have some opportunities to join forces, because my personal opinion is we've got lots of patients to take care of, and we don't have enough people with the skill set to do it. We also struggle as a profession because we don't have a national survey that tells us, like, how many neurorehabilitation psychologists do we need in the workforce? How many are retiring? How many are going to be needed in 2050? Now, we know that we have a general idea for physicians, we have a general idea for engineers, for school teachers, for nurses, but we don't have that for psychologists, and that's a problem. That's not anybody's fault here that's on this call, but at an organizational level, I think to get us to some of the things you're asking about will require the organizations to come around to saying, hey, we're a lot stronger if we can kind of join forces. But I think one of the reasons they're not joining forces is because they're still busy kind of building their profession and some of the core issues and getting those things straightened out. And I'm hopeful that once that happens and they really have a solid base and they feel really confident with who they are, they'll feel a lot more comfortable with the collaboration. I might have really stepped on some toes there. Maybe, I don't know what, I'd be real interested to hear what Kate and Carey have to say about that.
Yeah, it is that definitely a collaboration problem and it's a silo problem, and so to maybe answer the initial question a little bit, is there are those of us out there who have been fighting the good fight for decades, and I'm sure others have the same kind of mindset, is reach out and find us. So we've been carving a path and trying to build those collaborations and the openness. And so we're there to continue to mentor and to guide anybody that wants to do this, because it's so important. And I have given whole presentations with colleagues on just the power of having these 2 specialties together and wielding them. The power that it provides to patients is real and tangible, as well as financially for you being successful. Holy buckets. I mean, there is just, it opens up a huge world of all sorts of ways you can wield that specialty knowledge and make a difference. So don't be afraid to ask. Don't be afraid to reach out, and because we're out there happy to help. To keep the fields trying to move forward, all I can say is that we crazy people keep putting our hands up and volunteering our time, and try and keep forging the paths towards each other and recognizing, and I think this is one of the reasons I've come to that place in my career where I introduce myself as I'm a clinical psychologist, because that's my PhD is in clinical psychology. That's the hat that I put on, who specializes in honoring both these wonderful areas of practice and that they are not in conflict. They are actually synergistic and in beautiful ways, and we are not competing for patients. There are way too many patients that need to be seen. You know, you build it, they will come, and you know, it's opportunity abounds.
Okay, we've got just a couple more, or we've got time for a couple more questions. So I want to get to the one that we have in the chat, which is can you provide detailed information about the nitty-gritty daily workflow processes, inpatient versus outpatient, types of assessments or tasks administered, or the amount of intervention done?
I don't know if we have enough time to answer that. Especially since, I mean, you know, yeah, Kirk, go ahead and do it just for critical care setting, please. I mean, it would, yeah, I wonder if that could be nuanced a little of what nitty gritty I mean, what would be helpful? Is it the question of how do we weave those together? And
yes, that was my main question, was how do you weave the two together in your clinical practice?
So I'll just put a bigger picture, maybe a 30,000 foot view of this. So I definitely have time. So I'm all outpatient. When I started my career, I did inpatient. I, you know, was at Hopkins, the first psychologist to go on the critical care setting. So back 400 years ago. And so was really inpatient, all of the different realms, but now I've been outpatient for a number of reasons and for a number of years. So I carve out my practice so that I can have time to do the evaluations and then also have time to intervene. And then have time to be the training director of 3 postdoctoral fellowships and an externship. So, you know, yielding, you know, we're trying to wield all that. So I'd say you compartmentalize your time and allow yourself the time to do both pieces. And that includes actually doing co-treatments with physical therapy and occupational therapy to address intervention problems, especially for populations such as those with functional neurologic disorders. So it's you know, just carving out that time and the structure to do that.
I'll defer to Carey. Carey, we haven't heard from Carey on that. She can, and if there's time, I can add.
Yeah. So I guess the first thing that jumps out is the type of unit you're on. Like Dr. Bechtold was saying, like, you know, she kind of started out in the inpatient world and has evolved to outpatient. On at the VA Palo Alto, the 3 different brain injury units that we have, the Polytrauma Rehab Center is all inpatient, where the rehab neuropsychologists there, they split the patients, not the roles. So they integrate the neuropsych with the rehab psych by the very nature of literally the role that they do on that unit. On the post-acute unit where I am, Polytrauma Transitional Rehab Program, the neuropsychologist and I, Dr. Laughlin, split the roles, not the patients. So so she's the neuropsychologist and I'm the rehab psychologist on the unit. So what that certainly involves is a lot of good communication and collaboration between us, because in some ways it's sort of an artificial dichotomy to kind of separate the cognition from the emotion. And then on the outpatient unit, the rehab neuropsychologist, they integrate the roles again. So yeah, I would say, and then on spinal cord, they actually integrate the roles too. It's kind of unusual to have the roles split, at least at our hospital. So from that perspective, I am really able to spend a lot of time with the patients on the intervention some people say neuropsych is the what, and rehab psych is the now what or then what. And so, yeah, I mean, I'm fortunate to be able to, again, like the way that my career has evolved, to be able to focus on the passion of the intervention piece of it. Though I also know a lot of neuropsychologists or neuro rehab psychologists who also do a lot of cognitive rehab. So they'll do the neuropsych assessment and then we'll actually do a lot of the cognitive rehab too. So I think it really depends on the unit.
I think that's all very well said. I don't have a tremendous amount to add. The only other thing I'd say is my institution, I find that I'm doing a lot of directing care. So I might be working with the speech therapist on what interventions to do, or the OT, or even the behavioral health team. But there's just not enough of me to go around to meet the demand. So a lot of times I'm doing kind of more team direction, team leading, and that sort of thing. I'm still doing interventions in specific circumstances, but if there's situations where there's somebody else on the team that can do it, I have no problem with kind of helping them do that. Just because I kind of have to prioritize my time with where I'm at a level 1 trauma center, and we've downsized because of COVID, and the hospital has had budgetary issues, so I haven't been able to add back some of the staff that I lost. And so it's been really challenging because essentially the people know kind of what the skill sets and what's available, but now there's just not enough time in the day to meet all the demands.
I just want to thank all three of you for providing these different perspectives of, one, how you came to work in this area and the different paths, and then also just, you know, highlighting how rehab neuro can look different and how it can be in different settings, the collaborations that are necessary, and then also, you know, the specific competencies we can ask about as we go through our training to carve out these experiences. I was so appreciative of your time. And just so that everyone else is aware, this is part 2 of a 3-part series where the 3rd part will be continuing this conversation, but more specifically continuing to talk about how we can carve out a path in rehab neuro as applying for jobs if you're already in a setting in early career. That date will be announced further down the line, so keep an eye out on the different Division 40 and 22 listservs, as well as the various Instagram accounts. With that, I'll pass it to Gabby because she has the feedback form to share for today.
Yes, I just posted a link to the ANST feedback form. If everyone would please take 10 seconds to do it. It's 5 questions. It will take no time at all. So if everyone could do that, that would be really helpful. It really helps to directly inform our programming and the formatting of it. And yeah, it would just be helpful. But also, yes, thank you to our panel. This was really informative. I know I'm still in training, so I always learn a lot from our panel. Oh my gosh, I'm like having word finding issues, but from our panel. So thank you so much. I really appreciate it.
Thank you for having us. This is a great topic, and I'm glad folks are interested in it. We need more of you.
Yes, absolutely.
Agreed.
Well, thank you all, and keep an eye out for continued events and future programming, as well as hopefully a future compiled list of resources for the folks interested in this area.
Very good.
Take care, everyone.
Take care, everyone.
Thank
Bye
you so
now.
much. Bye-bye.
Thank